All right, so a very good evening, everyone. Right, so I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. So in this particular section, we will be discussing the previous year questions of the NEET MDS related to the general medicine, right? So let me start with the first question. All right, so most common cause of the nephrotic syndrome in adults. Anyone want to make an attempt of this? All right, yeah, so I'm having some of the answers. That is great. So the answer is the focal segmental glomerulosclerosis, right? So just give me 1 minute. Yes. So the answer is the focal segmental glomerulosclerosis. That is the most common cause. Now, how is that we should be able to rule out the other options, right? The other options that includes like the membranoproliferative glomerulonephritis, minimal change disease, and as well as diffuse glomeruloproliferative nephritis. How is that you'll be able to rule out the other options? So you take the membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis, it is not purely nephrotic and it is not purely nephritic. In these individuals, they will be having both nephrotic and as well as the nephritic picture as well. So that is how your first option is ruled out. And you take minimal change disease. Minimal change disease, this is the most common cause of the nephrotic syndrome in children, and it is not in the adults. And next is diffuse glomerulonephritis. This diffuse glomerulonephritis, it is not a specific disease entity, right? What diffuse tells you, it describes the extent. It is not the etiology. Okay. And this this diffuse glomerulonephritis, it is more often the cause for the nephritic picture, right? More often the cause for the nephritic picture rather than nephrotic picture. Okay, so here the etiology is what? That is focal segmental glomerulosclerosis. And focal segmental glomerulosclerosis, as the name itself tells you, right? Only few glomeruli, right? It is only the few glomeruli that will undergo sclerosis, and that too only part of the glomerulus will undergo sclerosis. That is what you will observe in case of focal segmental glomerulosclerosis, right? And in case of the FSGS, you have primary causes for FSGS and secondary causes for FSGS as well. And what are the secondary causes for FSGS? The secondary causes for FSGS, it includes mainly HIV. Then we have the hepatitis B virus. Then obesity is one of the cause for secondary focal segmental glomerulosclerosis, right? And how do you treat these patients? Primary focal segmental glomerulosclerosis, you need to give steroids, right? You need to give steroids in case of primary FSGS. Whereas secondary FSGS, you need to treat whatever is the underlying cause. That is what is your focal segmental glomerulosclerosis. Done? Now, that was the first question. And again, if the question is asked, like, what is the most common systemic disease that will be causing nephrotic syndrome in most common systemic disease that will be causing nephrotic syndrome in adults? The answer will be diabetes mellitus, right? So this is about the so most common cause of nephrotic syndrome in adults, right? The answer should be FSGS. Whereas most common systemic disease that will be causing nephrotic syndrome in adults, the answer should be diabetes mellitus. Okay, right. Then, yeah, 1 second. Okay, we'll move on to the next question. Yes, this is the next question. Commonest glomerulonephritis in adults. So you see the difference. The most common cause of nephrotic syndrome in adults, that was the first question. The answer is FSGS. But if the question is in this following manner, that is commonest glomerulonephritis in adults is IgA nephropathy, membranoproliferative glomerulonephritis, minimal change disease, then IgM nephropathy. What do you think is the answer? Right, very good, Hamna. That is the IgA nephropathy. So if you take the IgA nephropathy, this is the most common primary glomerulonephritis in adults worldwide. And what will be the presentation in patients with the IgA nephropathy? The presentation in case of the IgA nephropathy will be in the form of recurrent gross hematuria. Right, the most common cause of, one of the common cause for recurrent gross hematuria, it is your IgA nephropathy. And what is the investigation of choice in these patients with IgA nephropathy is you need to do biopsy. Okay, and that too, renal biopsy should be done. And what does the renal biopsy show? Renal biopsy will show the presence of IgA deposits within the mesangium. That is what is your IgA nephropathy. And what is the treatment for the IgA nephropathy? The treatment for IgA nephropathy is you need to give steroids. This is IgA nephropathy. And why the other options are incorrect? You take membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis, this is not a common cause for primary glomerulonephritis. More often it is like secondary, but it is not a common cause for primary glomerulonephritis. And you take this minimal change disease, this is a leading cause of nephrotic syndrome in children, right? And it is not in adults. The question asked is adults. And we don't have any terminology called IgM nephropathy, right? It is a controversial entity. We don't have IgM nephropathy. We have what is called IgA nephropathy, but not IgM nephropathy, right? So that is the reason why the answer here is the IgA nephropathy, right? And in this IgA nephropathy, presence of IgA in the mesangium is important, not the presence of IgA within the serum or the plasma. The IgA in the serum or the plasma will be like maybe normal also, but in mesangium, definitely there should be presence of the IgA, right? Next, we'll move on to the next question. Yeah, all of the following are the features of the Cushing syndrome except hypoglycemia, hirsutism, hypertension, poor wound healing. Anyone want to make an attempt of this question? Right. So in case of the Cushing syndrome, what is that you will not have is, yes, very good, Anvesh Panda, that is hypoglycemia will not be there. In fact, what these patients will be having, hyperglycemia, right? Why? Because in Cushing's there is elevated glucocorticoids. These elevated glucocorticoids, they increase hepatic gluconeogenesis, and that will result in hyperglycemia. And what about hirsutism? Yes, hirsutism, it is present in patients with the Cushing's, okay, and it is often accompanied by androgen excess, right? In patients with Cushing's, there can be androgen excess also, and this androgen excess, this will be responsible for hirsutism in case of the Cushing's. And what about hypertension? Yes, hypertension is also the feature of the Cushing's, right? Why? Because there is elevated glucocorticoids. These elevated glucocorticoids, they increase the sensitivity of the catecholamines, and that will result in hypertension. And these patients will also be having poor wound healing as well, right? Why? Because these patients, they will be having hyperglycemia. That is one point. And second important point is cortisol will cause protein catabolism. and there will also be immune suppression, right? Hyperglycemia, and as well as the immune suppression will be there in case of the Cushing's, and that is the reason why there will be poor wound healing. So what is the feature that you will not have in case of Cushing's? Hypoglycemia will not be there. What they will have is the hyperglycemia is being present in case of the Cushing's, right? And in short about the Cushing's, what is that you need to know? The earliest clinical manifestation in Cushing's will be obesity, and that too weight gain, basically a central obesity causing weight gain. And what is the first line investigation that you'll be doing? That is 24-hour urinary cortisol levels, or the overnight dexamethasone suppression test should be done. And what is the treatment of choice in case of Cushing's? In case of Cushing's, you need to do surgical resection of the tumor, right? And if the individual cannot undergo surgery, then what is the medical management? In the medical management, it is a ketoconazole that is a drug of choice in case of the Cushing's. So this is about the important points related to Cushing's. Next, we move on to a question related to the respiratory disorder. Yeah, which of the following AHI, that is apnea hypopnea index, will classify the obstructive sleep apnea into the severe category? 10 per hour, 15 per hour, 30 per hour, and more than 30 per hour. So when do you call the severe category? Right, very good, Anvesh Panda. So that is more than 30 per hour. Now you take 10 per hour, that is the first option. So this first option, we call this as the mild obstructive sleep apnea. In case of mild obstructive sleep apnea, how much should be your apnea hypopnea index? This should be around 5 to 15 per hour. And you take the second option, that is 15 per hour. So this we consider it as, right, this we consider it as the moderate obstructive sleep apnea. So moderate obstructive sleep apnea, the apnea hypopnea index, it is around 15 per hour, right? And if it is more than 30, right, so like moderate, it is like 15 to 30, and if it is more than 30, then we consider it as the severe obstructive sleep apnea, right? So this is about your how do you assess the severity of the obstructive sleep apnea, and what exactly is the treatment of choice in patients with obstructive sleep apnea? What is the treatment of choice in patients with the obstructive sleep apnea? Anyone? So the treatment of choice in patients with the obstructive sleep apnea will be continuous positive airway pressure ventilation. CPAP should be placed on these individuals for the betterment of the outcome. Okay. Now, so that was about one of the questions related to the respiratory system. Now, you see the next one. In a mechanically ventilated patients in ICU, which of the following does not show improvement in prognosis? Which of the following does not show improvement in prognosis? Control of the histamine, DVT prophylaxis, daily portable chest x-ray, sedation protocol. Yeah, very good, Anvesh Pandey. So your daily portable chest x-ray is not required in patients with the ICU. And what about other options? You take the control of the histamine. So basically control of histamine is nothing but you are reducing stress ulcers. Okay, basically it's a stress ulcer prophylaxis, right? Stress ulcer prophylaxis. SUP stands for stress ulcer prophylaxis. Stress ulcer prophylaxis reduces clinically significant gastrointestinal bleeding and as well as the requirement of the transfusion. Okay, so definitely it has a good mortality benefit, control of the histamine. And you take DVT prophylaxis. So pharmacological or mechanical prophylaxis, right? This will, now what is the pharmacological prophylaxis? The pharmacological prophylaxis is that you need to give anticoagulants, right? That is low molecular weight heparin or the fondaparinux should be given. And that is like the pharmacological prophylaxis. What is a mechanical prophylaxis? These individuals are advised for the pressure stockings. So these two will definitely improve the outcome in ventilated patients who is there in the ICU. And what about daily portal chest x-ray? See, A routine daily chest X-ray in a stable ventilated patient show no improvement in mortality, right? So only on demand you need to do imaging, right? There will be no improvement in mortality on doing the daily chest X-ray in a stable ventilated patient. And what about sedation protocol? How is this useful? So sedation protocol, this sedation is very, very important, right? Why? Because this light sedation, it targets shortened ventilation duration. And this sedation, it will also reduce the length of the ICU stay, right? And at the same time, it improves the prognosis in the individual. Okay, so that is what is the sedation protocol. So now what is not very important for the improvement of the prognosis in an individual, that is daily portable chest X-ray is not important, right? Next. Okay, abnormal and permanent bronchial dilatation is seen in bronchiectasis, bronchiolitis, emphysema, asthma. Anyone? Abnormal permanent bronchial dilatation is seen in right? Very good, Anvesh Pandey. So yeah, bronchiectasis. Yes, Anjali, you want about the sedation protocol. See, this sedation protocol, Anjali, this is for you. Sedation protocol, it will improve the prognosis. How it will improve the prognosis? How you should give sedation is, you should give protocolized, you should follow a protocol in the sedation, right? Where the individual should awaken for short time, and followed by that again there should be light sedation, and that will target shortening of the requirement of the ventilator. Ventilator duration will be reduced, and the sedation protocol will also lower the VAP risk, that is ventilator associated pneumonia risk will be reduced, and it will also reduce the ICU length of the stay, and overall it will improve the prognosis. That is about the sedation protocol. Now in this question, yeah, so abnormal and permanent dilatation of the airway is seen in case of the bronchiectasis. So in case of bronchiectasis, it is mainly the disorder of the medium-sized airways, and you will notice that there is irreversible dilatation of the medium-sized airway by more than 2 mm. Right? Irreversible dilatation of the medium-sized airway by more than 2 mm. That is what you will observe in case of the bronchiectasis. Whereas you take the second option, you take bronchiolitis. Bronchiolitis, it is not the dilatation of the airway. So basically this is the inflammation of the smaller airways. Right? It is only the inflammation of the small airways. And what about emphysema? Emphysema, it is not the bronchial dilatation. It is the permanent enlargement of the air spaces distal to the terminal bronchiole. That means what are abnormally dilated in case of emphysema? It is your alveoli which is irreversibly abnormally dilated. Next, coming to the asthma. Asthma, it is not a permanent dilatation of the bronchi or bronchiole. So this is a reversible airway disorder. Right? It is a reversible airway disorder, and that too, it is not like dilatation. In case of bronchial asthma, like what is that you will observe is, you will notice that there will be bronchoconstriction. You will not have bronchial dilatation in case of asthma. So that is how your asthma is ruled out. And you take bronchiectasis. Bronchiectasis, you will have the irreversible dilatation of the medium-sized airway by more than 2 mm. By more than 2 mm. Now, in case of bronchiectasis, what is the most common cause for bronchiectasis? Most common cause for bronchiectasis is your pneumonia. And what is the common clinical presentation in bronchiectasis? These individuals will be having cough with copious expectoration, and they can also have hemoptysis. And in bronchiectasis, one of the important examination finding is the presence of crepitations. And how will be the crepitations here? You will have leathery crepitations in case of the bronchiectasis, right? And in case of the bronchiectasis, the chest X-ray will show you a tram track appearance, and the CT scan of the chest will show you that there is a signet ring sign. And in the treatment, you need to give antibiotics, or chest physiotherapy should be done, where that secretions whichever are there within the dilated airways that are being completely expectorated out. So that is what you will observe in case of bronchiectasis, right? So the answer here is A. Now we'll move on to the next question. Yeah. So please answer this. Uthoff sign is seen in. Yes. Anyone want to make an attempt? Uthoff sign is seen in. So Uthoff sign, it is the classical sign seen in patients with, any guess? Right. So Uthoff sign, good. It is present in case of the multiple sclerosis, right? And what is this Uthoff sign or Uthoff's phenomena? Is that whenever these patients with multiple sclerosis, when they are exposed to heat, right, or whenever they are exposed to fever, I mean, whenever they develop fever, or when these individuals do exercise, what happens to these symptoms? There will be worsening of the symptoms, right? You will notice that there is worsening of the symptoms. That is what is your Uthoff's phenomena. So what happens whenever the individual is exposed to increased temperature is heat, right? Heat, it impairs the conduction in demyelinated axons. That is a problem in multiple sclerosis, right? And what about the other options? You take Bell's palsy. Bell's palsy, it is an idiopathic, right? It is an idiopathic lower motor neuron facial nerve palsy. And in case of Bell's palsy, there is no heat-induced worsening of the symptoms. And you take Parkinsonism. Parkinsonism, it is the disorder related to the basal ganglia. There is basal ganglia dopaminergic loss, and because of which the presentation in patients with Parkinsonism will be rigidity, akinesia, and as well as tremors, and postural instability will be there. And next about cerebral palsy. Cerebral palsy, it is like non-progressive motor disorder from perinatal brain injury. Okay. Right. So cerebral palsy, it is a non-progressive motor disorder from perinatal brain injury. And in case of cerebral palsy, there is no Uthoff's type of temperature dependence, right? So you'll have only in case of multiple sclerosis. And this multiple sclerosis, what exactly is it? It is a demyelinating disorder of the central nervous system, and it's an autoimmune disorder. And mainly in case of multiple sclerosis, can anyone tell me what will be the MRI finding in patients with multiple sclerosis? Anyone? What will be the MRI finding in patients with multiple sclerosis? So if you take the MRI finding in patients with the multiple sclerosis, you will notice that there is presence of, or there will be presence of Dawson's fingers. And what will be the drug of choice in case of the acute episodes of multiple sclerosis? You need to give steroids, right? Methylprednisolone should be given in acute episodes of the multiple sclerosis. Done? Now, so this was about your Uthoffs. We'll move on to the next question. Right. Which is a type of scleroderma here? Melkerson's-Rosenthal syndrome, Pierre-Robin sequence, Garden syndrome, then Parry-Romberg syndrome. Anyone? Just 1 minute. I'll connect my laptop to the charger. Just give me 1 minute. All right. So now, what is the answer to this question here is, no, it is not Melkerson's-Rosenthal syndrome. Melkersson-Rosenthal syndrome is that where there will be a recurrent facial paralysis, right? So which is a type of scleroderma. It is your Parry-Romberg syndrome. Parry-Romberg syndrome, it is the another name for this Parry-Romberg syndrome is, it is also called progressive hemifacial atrophy. That is called Parry-Romberg syndrome. And this Parry-Romberg syndrome, this is considered as localized form of scleroderma. Right? It is considered as a localized form of the scleroderma. Right? They will be having a slowly progressive atrophy of the skin. They will be having a slowly progressive atrophy of the skin, and there will be slowly progressive atrophy of the subcutaneous tissue, muscle, and sometimes bone on one side of the face. So these are all the structures which will get atrophied in case of Parry-Romberg syndrome, right? That is your skin, subcutaneous tissue, muscle, and bone on one side of the face. And this is like a form of scleroderma. And what about other options? You take Merkelson-Rosenthal syndrome. I'm sorry. So Merkelson-Rosenthal syndrome, it is a scenario where there will be facial paralysis. These patients will be having a fissured tongue, and these patients will be having the orofacial swelling will be there, right? And this is nowhere related to scleroderma. The next one is the Peary-Robin sequence. Peary-Robin sequence, it is a congenital sequence with micrognathia. Right? So it's a congenital sequence with micrognathia, and there will be glossoptosis, and these patients will also be having a cleft palate. Okay, so this will be the Peary-Robin sequence. Micrognathia, glossoptosis, and then you'll be having the presence of the cleft palate. Right? It is nowhere related to your scleroderma. And the next one is the Garden syndrome. Garden syndrome, it's a variant of familial adenomatous polyposis. Right? It is a variant of familial adenomatous polyposis, where you will have intestinal polyps, osteomas, epidermoid cysts, and dental anomalies will be there. And this is nowhere related to the scleroderma. Right? It is nowhere related to scleroderma. Okay. So this is about the type of scleroderma. In the options given to you is Parry-Romberg syndrome. Done. Now we'll move on to the next question. Yeah, Quincke's sign of aortic regurgitation is cyclical erythema and pale appearance on pressing nail bed, head movement with pulse, pistol shot sound over the femoral artery, prominent dorsalis pedis pulsations. Yes. Right. Now, in this question, yes. So what is that you will notice is, you will notice that there will be cyclical erythema and pale appearance on pressing the nail bed, right? Nail bed. Yeah, in case of Gardner's, Dr. Abdullah, the polyps which are present initially, they turn out to be malignant later. That is what will happen in Gardner syndrome. Okay, right. So in case of the Quincke's, in Quincke's, you will notice that you will be observing the pulsations over the nail bed. So basically what is that you will be doing is, you will be applying the pressure over the tip of the nail, and where you will notice that there is alternating flushing and blanching of the nail bed. Flushing and blanching of the nail bed with light pressure. That is what you will see in case of Quincke's. Then what about the other options? So head movement with the each pulse. So what is this called? This is called DBMCI sign. Right? This is called DBMCI sign. And pistol shot sounds over the femoral artery. What is this called? This is called Traub sign. And prominent dorsalis pedis pulsations. So basically it is a form of a bounding pulse. You don't have any name for this, but it is a form of a bounding pulse. Okay. So Quincke's is nothing but the cyclical erythema and pale appearance on pressing the nail bed is what is called the Quincke's sign. Is anyone aware of this needle? Quincke's needle. Where do we use this Quincke's needle? Anyone? Where is that we use this Quincke's needle? Yes, right. So Quincke's needle we use in lumbar puncture, right? Very good, Hamna. So for CSF analysis, you'll be using this Quincke's needle. Done. Now we move on to the next question. And remember all these signs, whatever we have discussed, the peripheral signs, that is pistol shot sounds, DBMCI sign, Quincke's sign, all these are present in chronic AR, but not in case of acute AR. Okay, right. See the next question. Depressed, backwardly placed sternum, prominent sharp angulated rib is known as. Right, very good, Hamna. So it is the scorbutic rosary. Scorbutic rosary. What about the other options? You take this rickety rosary. Rickety rosary, it is observed in the vitamin D deficiency, and that is due to overgrowth of cartilage at costochondral junction. And what is the chest that we describe in case of the rickety rosary is, we describe it as the pigeon chest in case of rickety rosary. And in rickety rosary, you will not have a depressed sternum. So first option ruled out. And you take the Hutchinson sign. What is this Hutchinson sign? Hutchinson sign is nothing but the vesicles on the tip or side of the nose. Right, vesicles over the tip or side of the nose in ophthalmic herpes zoster infection. Right, ophthalmic herpes zoster infection, the presence of the vesicles on the tip or side of the nose is what is nothing but the Hutchinson sign. Right, and again you should not confuse this with Hutchinson teeth. Where do you have this Hutchinson teeth? The Hutchinson teeth, it is observed in the congenital syphilis. Right, congenital syphilis. Then we have the trail sign. What is this trail sign? Trail sign, it is basically used in cardiology for pulsations felt in suprasternal notch in aortic arch aneurysm. Right, aortic arch aneurysm. Okay, so aortic arch aneurysm. So in aortic arch aneurysm, you will have the presence of the trail sign. And whatever the option, I mean, the question given to us, that is scorbutic rosary. And where do you have this scorbutic rosary? You'll be having this scorbutic rosary in case of vitamin C deficiency. And why is this due to? This is due to costochondral junction beading. But unlike rickets, the beads are sharp. Right? The beads are sharp, angulated, and very painful also. And this is associated with the depressed sternum. This is associated with depressed sternum, and prominent rib angulations will be there. That is what is here, the scorbutic rosary. Right? Next. Now we'll move on to the next question. Yeah, SSJ, I will be sending this PDF to the Telegram channel. We have this MDS Telegram channel. Onto the Telegram channel, I will be sending this PDF once the class is over. Right? Okay. Now, yes, you see the next question. Gene responsible for achondroplasia is GNAS1, fibroblast growth factor 3, FGFR3, ROR2, CBFA1. Very good. So, yeah, yes, Anvesha Panda and as well as Hamna, it is not GNAS1. It is your FGFR3. Now, where is that you will have GNAS1? So mutation of the GNAS1, you will have it in McCune-Albright syndrome. Right? In case of McCune-Albright syndrome, you will have the presence of GNAS1. And another condition where you will have GNAS1 is in conditions like pseudo-hypoparathyroidism. Right? In pseudo-hypoparathyroidism, you will have GNAS1 gene mutation. These are the two conditions where you will have GNAS1. McCune-Albright syndrome and pseudo-hypoparathyroidism. Right? And you take the FGFR3. FGFR3 is what is being mutated in case of the achondroplasia. Then we have ROR2. ROR2, it is a mutation of ROR2. It is seen in case of Robinow syndrome, right? We have a syndrome called Robinow syndrome. In case of the Robinow syndrome, you have this ROR2 mutation. And in Robinow syndrome, what will be the presentation? These patients will be having a short limbs, dwarfism will be there, and craniofacial anomalies will be there. And there will also be brachydactyly. So that is what you will observe in Robinow syndrome. And what about this CBFA1? CBFA1, that is nothing but your rungs actually, RUNX2. So CBFA1 gene mutation, that is RUNX2, this mutation is observed in case of cleidocranial dysostosis. Right, in cleidocranial dysostosis, you will have this CBFA1 mutation, right? So in case of CBFA1 mutation, these patients will be having a different skeletal dysplasia, but not achondroplasia. Okay. So what is being mutated in achondroplasia is FGFR3. Done. Now, so what are the other features in achondroplasia? Like you will be having the craniosynostosis, right? Craniosynostosis. Okay. Next. Now you see another question related to the genetics. Disease transmitted from father to all daughters would be Hamna, in cystic fibrosis, it is your CFTR gene. It is CFTR gene that is being mutated in case of cystic fibrosis. Okay. Yeah. Yes, SSG. I will just highlight the important topics at the end of this session. Okay. Right. Yeah. Answer this. Disease transmitted from father to all the daughters would be. Anyone? Right. So it is your X-linked diseases. Right. Very good, Anvesha Panda. That is X-linked diseases. So you take this X-linked diseases, the affected father will be having mutated X and as well as Y. So this X will be transmitted to the daughters. Right, this X will be transmitted to daughters. So affected father gives only X to all daughters. So the defective X will go to all daughters. Okay. So it is your X-linked disease. If the father is having this, then that will go to all the daughters. Then what about autosomal dominant? Affected father passes the mutant autosomal allele to 50% of their children. Right. Not all the daughters only. So 50% there is chance of transmission from the father to the children. Then what about autosomal recessive? Autosomal recessive, if father is affected and mother is normal, then all children are carrier. None of them are affected. If the father is affected, mother is normal, all the children are carrier, but they are not affected. And what about this mitochondrial? Paternal mitochondria, they are not transmitted. Paternal mitochondria, that means the mitochondria from the father, they are not transmitted. Right? Affected fathers pass the disorder to none of their children. To none of their children, the paternal mitochondria is being transmitted. Okay. So that was about the disease transmitted from father to all daughters would be. Next question. Yeah, you please see this question. Disease transmitted from mother to all children is. ఒక హాఫ్ అన్ అవర్లో వస్తా. Yes, disease transmitted from mother to all children is. Yes, so disease transmitted from mother to all children is your mitochondrial disease. So mitochondrial DNA is inherited only from the mother. Hence, all children inherit the defect. However, only daughters continue to pass it to the next generation. So it is your mitochondrial disorders. Mitochondrial disorders, they are the one, or mitochondrial DNA is the one which is inherited from the mother, from only mother to the children, right? Yeah, Sujay Singh, I'm trying to repeat this mitochondrial again. So mitochondrial DNA is inherited right? Mitochondrial DNA is inherited only from mother, right? Only from mother. So all children inherit the defect from the mother only. The mitochondrial disorder will be inherited only from the mother, not from the father. Fathers, they don't transmit or send the mitochondria to the children. Okay. Sujay Singh, did you understand that? Right. Okay, we'll move on to the next question. Okay. So ventricular septal defect showing reverse blood flow shunt is known as Eisenmenger anomaly, patent ductus arteriosus, Fallett's tetralogy, anomalous pulmonary venous return. Yes, anyone? VSD showing reverse blood flow shunt is known as. Very good, Hamna. So this is what is nothing but your Eisenmenger's anomaly. Okay. So what is that Eisenmenger's anomaly? Those individuals who are having, right, those individuals who are having long-standing VSD or long-standing ASD or long-standing PDA, right, long-standing VSD, ASD and as well as PDA, there will be reversal of the shunt, right? So initially the shunt will be from left to right, but later this shunt will become from right to left, right, from right to left. So this is what is called as the Eisenmenger's anomaly, right? So patent ductus arteriosus, if there is development of pulmonary hypertension in patent ductus arteriosus, this can turn into Eisenmenger's, but reversal of the flow is already observed in the Eisenmenger's anomaly. And in case of tetralogy of Fallot, right, these are your cyanotic congenital heart diseases. These are your cyanotic congenital heart diseases. And anomalous pulmonary venous connection. What is anomalous pulmonary venous connection? Pulmonary veins, normally they drain the blood into left atria. But instead of left atria, if the pulmonary veins, if they drain into right atria, that is called anomalous pulmonary venous connection. And this is also a cyanotic congenital heart disease, right? And even tetralogy of Fallot is also a cyanotic congenital heart disease, right? So reversal blood flow shunt is known as the Eisenmenger's, that is observed in VSD, ASD and as well as PDA. So in VSD, PDA and ASD, once there is a reversal, then we use a term called Eisenmenger's, right? Otherwise, if you take this ASD, VSD and as well as PDA, all of these are acyanotic congenital heart disease if there is no reversal. If it is only reversal, if it is being present, then we call it as the cyanotic congenital heart disease, right? So the answer is A in this question. Next, we'll move on to the next one. Irreversible dementia is caused by subarachnoid hemorrhage, Wilson's disease, vascular dementia, normal pressure hydrocephalus. Yeah, so in which condition you will be having the irreversible dementia? Right, very good, Anvesha Panda. So that is the vascular dementia. So vascular dementia, it is a form of the irreversible dementia. So basically what happens in case of vascular dementia is there will be multiple infarcts. Right, there will be multiple infarcts or there will be chronic ischemia. Right, multiple infarcts or chronic ischemia. So this multiple infarcts or chronic ischemia, this will lead to a permanent brain tissue loss. Right, so this will lead to a permanent brain tissue loss. And that is the reason why this will result in the irreversible dementia in case of vascular dementia. Whereas you take subarachnoid hemorrhage. In case of subarachnoid hemorrhage, this can cause acute cognitive decline, and these patients will be having a transient confusion. Right? These patients will be having transient confusion, and acute cognitive decline will be there in case of subarachnoid hemorrhage. And what about in case of Wilson's? In case of Wilson's also, there will be neuropsychiatric symptoms and cognitive decline. And the early diagnosis require the chelation, that is with zinc and as well as penicillamine. And your Wilson's, it is potentially reversible. Next is normal pressure hydrocephalus. Normal pressure hydrocephalus, they present with a triad. What is a triad? These patients will be having incontinence, and that we call it as wet. Next is they will be wobbling. That is nothing but gait abnormality. Gait disturbance will be there. And next is wobbling, wet, wobbling, wacky. Wacky is nothing but dementia. Right? Nothing but dementia. So dementia here, in case of normal pressure hydrocephalus, it is like reversible. Right? Once you do a VP shunt, once you do a ventriculoperitoneal shunt in case of normal pressure hydrocephalus, this dementia will be reversible. Right? But the condition where you have irreversible dementia, that is in case of the vascular dementia. Right? Next, we move on to the next one. Okay. So a patient comes to you with renal damage. Blood smear shows presence of thrombocytopenia and as well as schistocytes. What would be your presumptive diagnosis? Thrombotic thrombocytopenic purpura, tumor lysis syndrome, Sjogren syndrome, and then lymphoma. Blood smear shows thrombocytopenia and schistocytes. What would be your presumptive diagnosis? Right, very good, Anvesha Panda. So that is thrombotic thrombocytopenic purpura. So what will be the presentation in case of thrombotic thrombocytopenic purpura? Number one, microangiopathic hemolytic anemia will be there. Right, microangiopathic hemolytic anemia with schistocytes. And along with that, these patients will be having thrombocytopenia, where there will be like platelet dysfunction or platelet reduction will be there. And these patients will also be having renal dysfunction. Renal impairment will be there, where there will be increase in the creatinine. And these individuals will also have the neurological signs. These individuals will be having neurological signs, right? And these are the, and why does this TTP occur? This TTP occur mainly due to deficiency of the ADAM-TS13. Right? ADAM-TS13 deficiency is the one which will be causing thrombotic thrombocytopenic purpura, right? And this is about TTP. Then how will you rule out the other options? And this schistocytes are due to what? They are mainly due to microangiopathic hemolytic anemia. Then followed by that, you take tumor lysis syndrome. So tumor lysis syndrome, it is the scenario where the individual will be having acute kidney injury. And in patients with tumor lysis syndrome, you don't have the schistocytes. Schistocytes are absent. What are schistocytes? They are lysed RBC. Right? Lysed RBC. So you don't have schistocytes in case of your tumor lysis syndrome. Next is you take the third option, Sjogren syndrome. Sjogren syndrome, like what is the typical renal disease that they'll be having is renal tubular acidosis. So these patients, they can have either one or two subtype 1 or subtype 2 renal tubular acidosis will be there, right? And even in case of Sjogren's, this does not cause microangiopathic hemolytic anemia, right? This does not cause microangiopathic hemolytic anemia, right? And you have the presence of schistocytes. Okay, in case of the, sorry, there is no schistocytes, I'm sorry. There are no schistocytes in case of Sjogren's. And the next one is the lymphoma. So if you take this lymphoma, this can lead to a tumor lysis syndrome causing acute kidney injury. But again, even in case of lymphoma, there will be acute kidney injury, but you don't have this schistocytes, right? Schistocytes with thrombocytopenia, it is not the feature in case of the lymphoma. But where will you have like the schistocytes, thrombocytopenia and renal damage? That is in case of thrombotic thrombocytopenic purpura, and that is due to the ADAM TS13 deficiency, right? So this is about the question number 16, where it is about your TTP, thrombotic thrombocytopenic purpura. Done. Next. Yeah. Most important step in the management of acute diarrhea is fluid replacement, antibiotics, prokinetic drugs like metoclopramide, anti-motility drugs like loperamide. Yeah, very good, Anvesha Panda. So the first prior important thing is giving IV fluids, right? So if at all, if there is a death, if at all, if there is any morbidity in case of the acute diarrhea, the death or morbidity in acute diarrhea, it is mainly due to dehydration. It is mainly due to electrolyte loss, but it is not from pathogen per se. So that is the reason why the IV fluids that is in the form of normal saline or IV fluids in the form of the ringer lactate, they are the one which will restore the volume and they prevent the shock, right? Otherwise, the individual will progress to the development of the acute kidney injury and electrolyte abnormalities can be there. Now, you take antibiotics. See, most of these acute diarrheas, they are like self-limited. Antibiotics are reserved only for specific indications like cholera, traveler's diarrhea, dysentery, Shigella, Campylobacter, Clostridium difficile, immunocompromised individuals. In them, the antibiotics have to be given, but not in the scenario which has given to you. Not all the acute forms of diarrhea, you will be requiring the antibiotic. And you take the third option, that is prokinetic drugs. Prokinetic drugs like metoclopramide. Metoclopramide is used for nausea, vomiting, and gastroparesis. Right? It does not treat your diarrhea. But the problem with this, your metoclopramide is it can also cause extrapyramidal side effects as well. Next is the anti-motility drugs. Anti-motility drugs like loperamide, they can reduce the stool frequency in uncomplicated watery diarrhea. But this is contraindicated. Your loperamide, it is contraindicated in case of the bloody diarrhea. Right? And it is also contraindicated in case of the individuals who are having high fever. That is in case of the infective diarrhea also, you cannot give this anti-motility drugs like loperamide. Okay. If it is non-infective, then you can give this anti-motility drugs like loperamide, but not in case of infective diarrheas or in case of the bloody diarrheas. So that is the reason why the important step in the management of the acute diarrhea is supplementation of your IV fluids, right? So the answer is A in this question. Yeah. Iron deficiency anemia causes increased total iron binding capacity, increased serum ferritin, increased serum transferrin saturation, and increased serum iron. Yeah, anyone? So, right, very good, Anvesha Panda and Barsha Rani. That is increased total iron binding capacity. So, in case of iron deficiency, right, what will happen to your TIBC? The TIBC, that is total iron binding capacity, increases, right? And what about the serum ferritin levels? Ferritin is nothing but the iron depot. Okay, so ferritin levels will be reduced. And what about the transferrin saturation? The transferrin saturation, it falls in iron deficiency anemia. Transferrin saturation reduces. And what happens to the serum iron? Even the serum iron is also reduced. Even the serum iron is also reduced. Okay, so iron deficiency anemia causes what? It will cause increase in the total iron binding capacity, but not in the ferritin or transferrin saturation or the serum iron levels. Done. Now we'll take up one last question and then we'll wind up this session. Right. So we have a patient with sporadic ataxia. He should be checked for all except he should be checked for all accept. Right. So right. So this is one controversial question, right? So which of the following, I mean, yeah. So but if you see here, vitamin E deficiency, this can cause a treatable spinocerebellar ataxia. This can cause treatable spinocerebellar ataxia with neuropathy or retinitis pigmentosa. That is number one. And you take B1 deficiency. B1 deficiency, this will be causing Wernicke's encephalopathy, right? So even in case of the Wernicke's encephalopathy, what will be the features? You'll be having ataxia, you'll be having ophthalmoplegia, and you'll be having confusion as well. And what about the folic acid deficiency? Folic acid deficiency, this will cause the neurological impairment rarely, but mostly it is your hematological impairment will be there in case of the folic acid deficiency, right? But folic acid deficiency is also the one which will be responsible for cerebellar ataxia, right? It can also cause the cerebellar ataxia. And you take the TSH, right? TSH, that is hypothyroidism, it's a reversible cause for gait ataxia. Right, it is a reversible cause for gait ataxia, right? So out of all these, you take vitamin E deficiency, which is causing spinocerebellar ataxia. It is a rare form. Vitamin B1 deficiency causing ataxia in Wernicke's encephalopathy, that is like slightly common. Then folic acid deficiency causing cerebellar ataxia, it is uncommon. And TSH, hypothyroidism, which is a reversible cause for gait ataxia, this is also like uncommon. Now, almost all these options, they are responsible for the development of the ataxia, right? And if only one is being asked to select, if only one is being asked to select, then in such case, you just go with the folic acid deficiency. You go with the folic, because it is not very common. Folic acid deficiency, it commonly presents with like the hematological abnormalities like megaloblastic anemia, right? And folic acid deficiency is causing cerebellar ataxia. It is very, very rare. The other options, they can present with ataxias, right? But folic acid deficiency is presenting with ataxia. It is very, very rare. Okay. So this is about the discussion related to these questions, right? So these are some of the important questions that you need to know. And regarding the INI-CET from medicine perspective, right, what are the important topics? Diabetes in endocrinology, very, very important, without which the question paper will not be usually be there. And you take in case of the cardiology, infective endocarditis, very, very important, mainly the prophylaxis for dental procedures. That is very, very important, that need to be learnt by all of you. And the next important in nephrology, like nephrotic syndrome and nephritic syndromes. These are the two scenarios where the questions are being asked very, very frequently. And the next, you take the respiratory system. In case of respiratory system, mainly they'll be asking like COPD and as well as bronchial asthma. These are the two important areas where the questions are being asked. And you take in case of neurology, epilepsy is one important topic. And next to this epilepsy, meningitis. Meningitis is also another very, very important topic. So these are some of the very important topics that you need to know. Yeah, Sujay, you want question number 18 again? Yeah, that is the iron deficiency. So iron deficiency, it causes what? It causes the increase in total iron binding capacity. But whereas serum ferritin level and the transferrin saturation and serum iron levels will be reduced, right? So with this, I'll wind up this particular session and I wish you all the very best, right? So please don't panic in the last moments, right? So you have definitely put extreme efforts all these days you have put completely an extreme effort. Always stay with a positive hope and as well as a positive attitude, right? And that is the one which will make you to progress in the life rather than like self-doubting. So don't get this particular self-doubt that will completely ruin your progress, that will make you completely depressed. So you should be like completely motivated every day, and you should be with that positive attitude. And whatever the exams we are conducting, or whatever the exams you are going through, what exactly they test is, they don't test your marks actually. They will actually test you the resistance of you giving up, right? How much resistant you are in giving up your final exam. That is what the exams will actually test you. So you need to stay very strong in these last moments, because all the preparation whatever you have done these months will completely go waste if you are depressed or demotivated in this last month. So stay hopeful, stay positive, and definitely you will crack the exam, and I wish you all the very best.